Let's talk about prediction and prevention of spontaneous preterm birth. Background: 10% of preterm delivery rate. Black women had a 50% higher preterm birth rate than other races at 15%. 5% of nulliparous women will have a preterm delivery. Risk factors: BMI lower than 18.5, smoking, short interval pregnancy less than 18 months, history of DNC, UTI, BV, periodontal disease during current pregnancy, and the treatment of BV and UTI does not reduce the preterm birth rate. However, the reason we treat the asymptomatic UTI is to prevent progression to pyelo. Twins is also a risk factor. 60% preterm birth rate. 20% is before 34 weeks. At triplets, it's at 98%. Short cervix, less than 25 millimeters. Bishop score of 4 plus in the second trimester. Excision of greater than 15 millimeter. After a LEEP procedure, patients should wait at least 3 months before trying. Strategies to assess risk. Cervical length should be done around 18 to 24 weeks. A probe in the anterior fornix and 3 measurements is taken, and the shortest one is recorded. Debris or sludge in the intraamniotic fluid is associated with additional risk. Funneling change with pressure is not predictive. Less than 35 millimeter on abdominal cervical length identify 100% of patients with vaginal ultrasound of 20 millimeter or less. Patient So if the patient had a singleton pregnancy with no prior preterm delivery, we just visualize the cervix at the anatomy ultrasound. Then that's it. If the patient has a singleton pregnancy with a prior preterm delivery, 35% will have another preterm delivery. If their cervix is 25 millimeter prior to 24 weeks, they are high risk for preterm delivery with a 65% sensitivity before 35 weeks. These patients with singleton pregnancy and prior preterm deliveries, they should have serial ultrasound 1 to 4 weeks, starting at 16 weeks until 24 weeks. Multiple gestation, 25 millimeter at 20 weeks has a positive predictive value of 70% for preterm labor before 37 weeks and 25% PPV before 28 weeks. Less than 20 millimeter the PPV is 60% before 34 weeks. However, these patients will only also do a cervical length check at anatomy ultrasound. Patient with history of medically indicated preterm delivery. Prior 35-week delivery patients has a 10 times risk of preterm delivery again, regardless of the reason. There is no recommendation for serial cervical length surveillance. We should work on reducing the underlying medical condition that caused the preterm delivery, such as given ASA for preeclampsia. So these medically indicated preterm deliveries, we don't recommend serial cervical length surveillance, unlike the ones that had a spontaneous preterm delivery, huh? Intervention for short cervix. Singleton, no prior delivery, found to have a short cervix. We give vaginal progesterone. It significantly reduced the preterm delivery rate before 34 weeks. Most studies use 20 milligrams of progesterone daily up to 37 weeks. We don't use IM progesterone anymore. So cerclage, when do we use cerclage? Ultrasound indicated cerclage. So when we do the ultrasound and we find the cervix is less than 10 millimeter, we can offer the patient a cerclage, decrease the risk from 60% to 40% for delivery before 35 weeks. Then we have the exam indicated cerclages for a dilated cervix. This is for patients between 16 to 23 and 6 weeks with a dilated cervix. But what are the contraindications? Fetal anomaly incompatible with life, intrauterine infection. One can consider amniocentesis prior to the cerclage to rule out infection. We can also give indomethacin and perioperative antibiotics to possibly prolong the pregnancy. Other contraindications include active bleeding, active labor, and PPROM. Transabdominal cerclage is reserved for anatomical limitations, such as patients with trachelectomy, a failed vaginal cerclage that resulted in a second trimester loss. This is placed around 10 to 14 weeks and is left in place between pregnancies. So if the patient had a prior preterm delivery, we suggest using vaginal progesterone and serial cervical exams starting at 16 weeks up to 24. If short cervix, we offer cerclage. Multiple gestation. There's a lack of definitive data for vaginal progesterone. However, for cerclages, you can offer the patient for possible benefit if the Cervix is dilated between 1 to 5 centimeters between 16 to 24 weeks.